everybody. I'm Dr. Quintin Mendoza, and today we are here to present a very interesting topic, which is menopause and weight management. I wanted to start first. Actually, I changed the order how this topic was provided to me because it was supposed to be weight management first. But since this is about menopause, let's talk a little bit about menopause first. So, menopause is, let me see how do I move around for next slide. How do I, yeah, change that? Okay. All right. So do I change it on here?
Yeah, you
How
can
do
use the cursor.
Okay, got
There
it.
it goes.
Got it. Okay, perfect. So menopause. So what is menopause? Is by definition 12 months, so 1 year completed without seeing your menstrual cycle. And this is when the amenorrhea, which is lack of menses, is not related with surgery. So if you did had a surgery, a hysterectomy at 40 years old, and now you don't see your cycle, so this is not menopause. Your ovaries are still working. You just don't have your uterus. And because of the surgery, you don't see your menses. So that's not related with menopause specifically. So why does this happen is because ovarian follicular depletion. So I figure this may be a little bit complex, these three terms. So I'm gonna do a parenthesis here and talk about ovarian follicles. So when we are born with the amount of follicles for the rest of our life. So actually when your mother was pregnant with you and you were 20 weeks of age in your mother's womb, you had approximately about 4 to 5 millions of eggs in your ovaries already. So just to have an idea, when you're born, you already have half of it. So you already have around 2 millions. It sounds like a lot, but then during puberty, you have half of that. So you have around 500,000. And then by menopause, then you mainly don't have any. So these are your eggs. So your eggs that are produced by the ovaries does decrease with the time. And the eggs are the ones and the ovaries that are in charge to produce your hormones, which is estrogen. So estrogen is the main hormone that decreases during menopause. So now we can go back. Usually happens, every patient is different, but the median age of this happening is around 51 years old. It could happen 4 years before, around 4 years after. When menopause happens around 45 years old, then we call that early menopause. When it happens less than 40 years old, 40 years old and younger, then it's called primary ovarian insufficiency. And of course, there are iatrogenic forms of menopause also. So if we for some reason had to remove both of your ovaries, now we are talking that now you don't have the ovaries, you don't have your eggs, and now you don't have your estrogen. That is one of the causes of iatrogenic menopause, and that could happen, but I'm removing your ovaries, okay? So at that point, you won't see your cycles. There is a period that is called perimenopause. So this is when the hormone starts changing. Usually happens around 4 years before menopause. So every patient is different. Your cycle, you may notice that may start changing. You may see your cycles actually more frequent. So before you were seeing your cycles every 28 days, and then suddenly you have seen your cycles, for example, every 21, 24 days. That happens during menopause because of that fluctuation of the hormones estrogen and progesterone. Most of the patients we have hot flashes, 80% of patients. And these symptoms could happen during perimenopause. So you may still have in your cycles every month, very regular, every 24 days, 21 days. And you may start with the hot flashes, and that happens very often. So hot flashes is an extreme heat sensation, happens usually in the upper body, then get diffused in your entire body. Thanks God usually just lasts for a few minutes, 2 to 4 minutes. But during that time, you may feel a lot of sweating, red discolor face or upper body, shivering, chills, and then all that may give you sensation of anxiety, and then it will go away. When all these happen at nighttime, we call it hot flashes. Then these symptoms may interfere with sleep because you are waking up every so often. You put your blanket because you're so cold, then you have to remove your blanket, then you're sweating, then you put a feet out a little bit, so you are in between. It causes lack of concentration because of the sleep disturbance. It's not because suddenly you are have any problem with the sleep itself, but because of the night sweats, then the sleeping is not that comfortable. And of course, your mood and your libido and the work and everything will interfere with this. I'm just gonna give you a few seconds to look at this, and this is some of the common symptoms of menopause. So sleep disturbance, mood changes, genital urinary symptoms of menopause. This is a nice way to say vaginal dryness, elevated cholesterol levels, and bone loss. All these may be related with the lack of estrogen. Remember that menopause, basically your ovaries that are in charge to produce your estrogen, stop working or nearly stop working. So now all this interferes with your symptoms. I have a lot of patients asking me about dementia or telling me, well, not really dementia, but I have noticed since I'm getting older, now my memory is not that good. I have to find some words when I want to define what I want to tell to somebody else. So this is limited evidence. We don't have anything that suggests that this is actually related with menopause itself. I have to remember you that menopause is not a disease. It's a physiologic state for every woman. It does happen. It's not a disease. It's a normal aging process. It may be related with the aging and more than estrogen related. Otherwise, if you think about it, if it was related with menopause, means that if I give you what you're lacking, which is estrogen, then your memory will come back. And it doesn't happen. There has been studies out there that if you're lacking estrogen, you're postmenopausal, then I give you estrogen, this doesn't change. So this is just limited evidence. There is not a lot of proof of that. So now we know what is the problem. We have all these symptoms. Everybody hopefully will get there. Um, some will have all of the symptoms. Some patients are very lucky and don't have any symptoms at all, which is great. So now that we know the problems, I think it will be great to talk about what we're gonna do about it. Three, management as most of the disease in medicine. The first management is behavioral modification. And I think most of the patients already do that by themselves. Behavioral modification means what is your problem? What is your main concern, your main symptoms? It hot flashes. So I have to tell you, maybe use loose clothes, don't open the air, your windows during winter, air conditioning, doing respiration exercise, doing breathing exercise. Perfect. What happened here? And drinking a lot of cold beverages also may help. Doing yoga. And not sure what happened here, of course. So most of the patients do that by themselves. They come, well, this I'm too hot, so I'm just having the air conditioner. Everybody at home is freezing, but I need to have my house at 60, and that happens, and that does help. That's the first line treatment. Less invasive, it's not a medication, you won't have any side effects. It may not work, okay, but yeah, that's fine.
Let's see, we downloaded it, so I bet it's here.
By the way, I went to the wrong library. I called them.
Tell them.
Oh, so I had to tell them. I just decided to go to Paramus Public Library for some reason. I do apologize.
It's a nice
I,
library.
well, I live in Paramus, and my kid just asked me where was I going. I'm like, oh, go here, right here in the library. And then I go there, and they have a kids meeting or something. I'm like, oh, maybe not. I don't think so. This is my audience for today. I'm talking about menopause.
Okay.
Okay, great. So we said this limited evidence. So behavioral modification, it's the first line treatment for any disease, for any of them. And it's not different for menopause. So behavioral modifications out there. If it doesn't work or still this is you still have some significant symptoms, then we go to medical management. Medical management is pills, is well, I'm gonna take that out. It's medication, not necessarily pill. So we manage what the patient is complaining. Some patients are okay in terms of the hot flashes because they're able to sleep in a fresh environment and cold environment, and that's fine. But if you think about it, opening the window is not going to resolve your vaginal dryness. So if the main complaint is just the vaginal dryness, we do vaginal cream, which is estrogen, which is what is lacking. During vaginal dryness, what happens is due to age and due to lack of estrogen, the vagina gets white. It loses the elasticity of the vaginal wall. It loses the lubrication. That lubrication usually happens before intercourse, happens lubrication. And then with the vaginal dryness and lack of collagen, intercourse may be more uncomfortable and more painful. This may present with some soreness after intercourse, feeling itching. Some patients even report white, yellowish vaginal discharge. Usually it's not an infection, it's just atrophic vaginitis due to the vaginal dryness and lack of estrogen. Having said that, the treatment of this is local, is estrogen therapy, and we have multiple presentations. We have cream, we have pills, vaginal pills, and also vaginal cream just the outside and ovules that you can insert inside the vagina. Usually this is a long-term treatment. It's not like when you have an infection, you will take these antibiotics for 7 days and you'll be cured. In that case, it will be a longer time and multiple presentations of them. There are minimal side effects, but some patients, there is some estrogen absorption systemic in your body. So some patients will report that they have some breast soreness. Actually, they feel that the breast is getting a little bit bigger or sore, just like when we were getting our cycles before, and just with your cycles, you have that extra peak of estrogen and you have some breast sensitivity that may happen during estrogen. But remember that mainly estrogen cream is local, so a little bit of absorption. So even in patients that had history of breast cancer, cholesterol, and other side effects, other contraindications that I'm going to mention after, we should be able to still use the local estrogen. So that is not an absolute contraindication for the estrogen. So we can still use it. In patients that have some contraindication, we can use it for limited time also, for the short amount of time. Before the topical estrogen, if it's just dryness, sometimes we want to try first something without hormones. Maybe you can use just water-based lubrication. We can use KY jelly, coconut oil, any lubrication if the problem is just the dryness with the intercourse. And of course, this is going to be just momentarily for the moment of intercourse, that may help. Otherwise, the estrogen cream has a little bit more or longer relief of the symptoms. And then going to the pills. Pills comes with or without progesterone. So when do I decide if the patient needs progesterone? So the pills is gonna take care usually of any menopausal symptoms. So the hot flashes, the vaginal dryness too. So if you're doing pills, you don't need to go to the topical cream. Only the pills will take care of everything. In patients that have a uterus, we need to add the progesterone because the progesterone will protect the uterus against the possible side effect of the estrogen. So basically, estrogen may make the inside of the uterus on the endometrial cavity a little bit thicker, which is not good. And then the progesterone make it thin. So there is a balance between thickness and thinness of the endometrial cavity. So we usually do it all together. Whenever we start in estrogen therapy, we do progesterone therapy. We have a couple of contraindications. So before we identify if the patient is a good candidate for this, we have to do a specific history and examination. Can I have the next slide? I think right now it's not really moving. Oh, got it, got it, got it. Okay. So for the estrogen, there are two main side effects, which are CVA, so coronary vascular disease, and also deep vein thrombosis or any uh, pulmonary embolism, basically blood clots. So in any patient that had a history or specifically a personal history or any deep vein thrombosis or pulmonary embolism, it is completely contraindicated because estrogen does increase the risk of blood clots. In patients that already had an MI, the patient had a stroke, this is a patient that we don't want to use it, and maybe we can use any other alternative, especially for patients having the hot flashes. And usually this is very interesting is that when you think in estrogen, most of my patients say, well, how about breast cancer? It has been proven that actually estrogen alone doesn't really increase the risk of breast cancer. But when we use a combination of estrogen and progesterone, especially in patients that have history, personal history, strong family history of breast cancer, estrogen and progesterone both together may increase the risk of breast cancer. So we don't use it again in patients with CVA, patient with history of blood clots, and patient with history of MI, patient with history of stroke, we try not to use it. So we want to make sure before we start that the patient is otherwise healthy and doesn't have any of these risk factors. You will say, well, if it's just estrogen, I have limited option to treat the hot flashes. There is one more medication that can, or a few more medications that can be used. But the most common one is what is called SSRIs or SNRIs. These are a group of medications that are primary meant to be for depression, like paroxetine. Zoloft is one of the medications, but it's used less frequent. So paroxetine is the first one that was studied, and it has been approved by the FDA. And this paroxetine has been proven that decrease the amount of the episode of hot flashes that you may have during the day. Have to be realistic and speak with the patient about their goal. None of this may completely resolve all the hot flashes, but decrease the number of hot flashes. So if you're having 5 a day and you go down to 2, that's pretty good. So it's not gonna make them improve. Some patients are very lucky and it may disappear completely, but that's not the goal. The goal is to make the patient more comfortable. So that will happen. So either estrogen, progesterone, if you do have your uterus, any contraindication, we do non-hormonal therapy, which will be SSRIs or SNRIs, which are antidepressant medication. That may help with your mood too. So if you're depressed and also you have some hot flashes, that may be a good primary option for you as well. All right. So now what everybody wants to know is what happened with the weight. I think this week, most of my patients have this complaint. I'm doing exercise every day. Nothing has changed. For the last 10 years, I wake up 5 a.m. in the morning, run for 1 hour, but now it's harder to maintain my weight. Some of them may be gaining weight. Some of them is just harder to maintain you being 150 pounds, and now you have to starve yourself just to be 150 pounds and don't gain 1 more pound. What happened? Why am I gaining weight? Or why am I just not losing weight? Nothing has changed. A lot of my patients tell me that nothing has changed. My diet is the same. I'm not eating more. And I do the same exercise. I still do exercise every day. The answer is right there, the last one. The problem is that you're doing the same and your body is changing, but the behavior that you're doing is not changing. So this is the problem right there. I have not changed anything. That's great that you're doing exercise and you're counting your calories. However, with age, your metabolism decreases, and that's the main problem. So whatever calories you needed before, right now, after 40 years old, not 51, not postmenopausal, after 40, 42, 45 years old, the metabolism decrease. So now doing the same, eating the same diet, and doing exercise 30 minutes 3 times a week because you always did and always worked for you is not going to work right now. So now we need to work harder on that. So you're not doing anything wrong. Your body is slowing down. So now you need less calories. And this is what happened. Very common complaint, multiple days, multiple times in a day, I hear it. Your metabolism is slowing down. Now you don't need so many calories. And this may not be reassuring, but this is exactly what I found. If eating and exercise habit are not changed, it will result in weight gain. And it does start at 45 to 54 years old. And actually, there was a trial progesterone estrogen intervention in postmenopausal patients that found that patients premenopausal, so it's not related to estrogen or progesterone necessarily. So starting at 45 years old, there is more weight gain, especially fat collection in the hips, than in patients postmenopausal more than 64 years old. And not only that, women who report more activities, and I think this was supposed to be a good news when I read it for the first time. It was shocking to me. It said women who reported more activities gain less weight than women who do less activities. So depending how you want to see, you want to see the glass half empty or half full, that they're telling me you're going to gain weight, but less. So keep doing exercise and just count your calories. So what is happening with my weight? Also, there is discrepancy on the literature. Most of them I found that it is not related with the estrogen. Otherwise, why at 45 years old, they found more fat accumulation and all that. So it's not related with that. Otherwise, in patients that if I give you estrogen, you should lose weight, right? So that's not happening. But the body compositions change. It has been a link between the fat distribution in the abdomen and loss of muscle mass with estrogen. So you may gain more weight. You may need just a little bit more effort and maybe increase your exercise. But if I give you estrogen or hormone replacement therapy, what they found is you have less fat distribution in the abdomen and you have less loss of muscle mass. So you will still gain your muscle. So that's a good news in there. Um, so overall, they have found this is a swan story that in over 6 years we may gain around 5 pounds. There is no dietary changes. Increase the fat, the mass of the fat, also increasing the waist. Estrogen, as I said before, it won't prevent the weight gain, but it does decrease the fat distribution around the abdomen. Patients with estrogen and progesterone therapy, they found that they lose less muscle mass. And as I said before, the fat distribution. And however, overall, the BMI stays the same. So I'm just going to do a parenthesis here and talk a little bit about BMI. So BMI is a calculation that we do to classify by weight patients that have normal weight, overweight, obesity times 1 to 1.3. It is calculated by weight divided by height. And normal is, I just rounded up because it's easier. 18.5 to 25 is normal. Overweight 25 to 29. Obesity is more than 30. 30 to 35 is obesity type 1, 35 to 40 type 2, and more than 40 is morbid obese. All right. So that's that. What I found is that in the history now, the FDA, we have less accurate information in the back of our food that we buy in all the supermarkets. They're not that accurate, or they give you just partial information, which is what you want to see. For example, you may find a milk which is 0% fat, but some of the milk may have more sugar. So we have to be careful when we're reading the back of our nutrients. There has been a dramatic change in the calories or the accessibility to the calories that we're doing right now, that we're eating right now. So just an example, in 1970s, the calories that we used to eat in one day was around 2,400 overall. In the 2000s, I'm pretty sure now 2023, maybe more than that, routinely we eat around 2,900 calories a day. This is 500 calories a day. So I don't know if I have somebody here that is good at math, not like me. I have to really struggle with these numbers, but I'm gonna go next. Let's do some math together. So the difference between this, what we have increased in everyday consumption is 500. 500 milligrams. So if it, sorry, calories, if you calculate that by 30 days, sometimes 31 days or 28, but 30 days, we are increasing every month 15,000 calories a month. But you will say, okay, calories, but what does that mean in weight? I'll tell you right now. 1 pound is 3,500 calories. Having said that, 3,500 calories is 1 pound. So that means that if I'm using that 15,000 calories, how many pounds is that a month? It's around 4 pounds a month. Of course, you say, well, but I don't gain 4 pounds a month. Well, you don't because you're running around, maybe you have kids, maybe you're doing exercise, so you're not keeping all of the calories that you're eating. We do, even if you don't do exercise, just because you're breathing, you're burning some calories. And just because you work from the python here, we're burning some calories, but we don't, this is how much we're gonna gain. But not everything is bad news. I'll give you some other numbers. Let's do math again. So that I know I've given a lot of bad news, but here is good. Let's count calories again. So if we do 500 less calories a day, we have 7 days. Let's say we're good every day. That doesn't happen to me, but let's say you're good every day with your diet and you every day you eat, either you eat 500 less calories a day or you're burning 500 calories that you were not burning before. Now you decide that you are going to run every day and you're going to burn 500 calories. Times 7 means that in a week, 500 times 7 is 3,500 calories, which is 1 pound. So if we decided to use 500 more calories a day, which is around 3,500 calories a week, means that you could easily lose 1 pound a week, which is 4 pounds a month, going back to that 4 pounds that we did gain before. So this is the input that I want you to take today if you're taking something from this lecture. And okay, I know some patients say, well, I don't eat, I don't do this, I don't do that. Something that I did skip before is the main problem that happened with aging is slowing in the metabolism. What are things that may increase the metabolism is eating more frequently. My mother she doesn't trust me. But I tell my mother every day, Mom, you need to eat multiple times a day. Eating 2 times a day is not going to help you to lose weight. What is the answer that I have back? I'm pretty sure maybe some of you think the same as well. But if I'm this way, eating 2 times a day, how are you going to tell me to eat 5 times a day? Yes, but you have to choose what you're eating 5 times a day. When you eat 3 times a day and 3 snacks during the day, small healthy portions increases the metabolism because your body is working more. So eating snacks, don't skipping meals. 3 meals a day is small, and 3 snacks during the day, 2 to 3 snacks a day, that will increase the metabolism. Doing weight bearing exercise will increase the metabolism. And some of us just want to run and burn 500 calories, but that is I want to see the numbers, how many calories I burn when I run for half an hour, right? My goal is 300, half an hour. So you won't see those numbers when you do weight bearing exercise, but long term, it does increases the metabolism and you may lose more weight or more easy when you do that. So weight bearing exercise, and I'm not saying cardio is not good, but weight bearing exercise is what is going to protect your bones. It does increase the calcium. It will decrease the risk of osteoporosis. So weight bearing exercise is very, very important. And do the cardio. Okay, fine, you can do it. And so that's one of the things that we can do to increase metabolism. All right. So what is the treatment of that besides all that we know? We all know that you have to eat less, do more exercise, all that. Okay. Behavioral modification, like I said before, that we spoke about it a little bit. And then we have some medical management with pills. And then we do have the last resource, most of the treatments, which is surgery. For medical management, we will pills. Some of the pills that is very famous right now is Ozempic. uh, yeah, in patients that have diabetes, that's a very good option. It's a GLP-1. It is very good. It's gonna slow your sugar. In patients that don't have diabetes, and I'm not gonna go there because I'm not a weight specialist, but it can have the side effects like any medication. But if you don't have diabetes and you're taking a diabetes medication every day that may slow your sugar, we may be concerned about hypoglycemia, which could be very, very dangerous. But that's one of the things that it could be used. It's not indicated to everybody, so there is some requirements that we need to meet to do that. So being either overweight plus a comorbidity. Comorbidity means you have hypertension, you have diabetes, you do have renal disease, you have other diseases, and you just overweight. You may be a candidate for medical management, so you can talk that with your PCP, or you have obesity times one without comorbidity. You can be a good candidate for medication. And the last resort would be surgery, and surgery is just for patients that have class 2 obesity, so 35 BMI or more, with comorbidities or type 3 without comorbidity. All right, so those are all the management that we can do for weight. And if you want to take some time and look at where you are, I don't know if you want to do that. I'm in the green. I'm 5'4", 150. I'm overweight. I've been most of my life. I've been there in the green. All right, and it is right there. I think this is my last slide. I will take any questions that you may have. Sure. We have, I'm not sure if we're talking about the same thing. We have a lot of different presentations of the hormones therapy with estrogen and progesterone. One of them looks like a sticker, it's a patch. So it is like a band-aid. You can put it anywhere, and we have some birth control options with the same, but different doses. Birth control options also have estrogen and progesterone. And even though it's birth control, it still may work for, it's estrogen and progesterone. So different doses will still work for menopausal symptoms. So we do have we have those patches, you put it in your body anywhere, not in your breast because it's estrogen. We have also pills that I have said before. We have a vaginal ring. It's like a rubber. I'm not sure if it's rubber. Looks like it's a flexible material. It's like a ring, and it goes in the vagina. You leave it there, remove it every so often based on the dose of the medication, but it doesn't have to be changed every day. And yeah, there is different presentations of that. Patches, some patients don't want to do like take a pill every day because they will forget. So yeah, we have the vaginal ring, stays in the vagina. We have the sticker, stays there. Some patients are very sensitive, may cause skin reaction just because it's sticky. So different presentations. Oh yeah, sure. So we were talking about different presentations of the estrogen or the hormone replacement therapy. Yes, yes, yeah. Yes. So I have a question very important. So in patients that have contraindication for hormone replacement therapy, do you have other options? So yes, in patients, let's start, hot flashes is the most common complaint. in patients. So for that, in patients that are contraindication for estrogen, we can use the antidepressant medication that I spoke before. So either SSRIs or SNRIs. The one that has been studied the most is the paroxetine, which is an SNRI. So it is an antidepressant medication, but it has been proven that decrease the number of episodes of the hot flashes. That's in terms of genital hot flashes. For vaginal dryness, we start with the behavioral modification as well. So we can use hyaluronic acid. Hyaluronic acid is one of the components that is facial, but it comes in vaginal presentation too. That would increase the elasticity, the mucosity, the lubrication of the vaginal area. If the problem is just the dryness, water-based lubrication may work for you. So that's one of the options. And also KY jelly, coconut oil, all these are options that don't have any estrogen. However, remember that also estrogen cream, we can use it in most of the patients that have contraindication for estrogen because most of the effect is local. So it will stay just in the vaginal area, it's not systemic. A minimal absorption is given. Can happen. Yes, yes, yeah. So, in the literature, depending what you're looking for, you find resources that will agree with whatever you're looking for. So, depending when you read, I'm pretty sure there is a lot of Oh, the question here was about fasting, about intermittent fasting. That happens very, very common, especially in young patients and also all ages. So there are literature that support a lot about intermittent fasting. It does work. It does work. However, it is not something that is long term, that can be a lifestyle. So you can do it for a month, but not for the rest of your life. I think it does interfere with your mood when you are intermittent fasting, that you are not able to eat at the time that you want to eat, that you are not able to eat what you want to eat at that time. And we all deal with that. It depends. Every patient is different. It may work for you, it may not. In terms of working in your metabolism, it's going to do nothing about your metabolism. Okay, doing small frequent meals is what is going to keep your body working all the time. Okay, I need to burn this food because I just ate it in 2 hours. When I eat again, so I have to use it. So that's how the body works. Yeah, so it is recommended to follow more than in terms of which diet is better to lose weight. It's recommended to follow more Mediterranean diet. So if you think about it, it's more like a lot of raw, a lot of vegetables, feta cheese, onions, nuts, yogurt. All this is very healthy. Right now, unfortunately, what I see in my kids, and I'm half guilty about it, is that there is a lot of accessible non-healthy food, which is easier and is more provided and is maybe cheaper and it may be easier to handle, right? So right now, unfortunately, our diet is more in general. When I say ours, is a lot of fries, a lot of fat in the diet, a lot of carbohydrate, and we are eating less and less food that is raw. And when I say raw, how about you put carrots, raw cucumbers, oranges, grapes. So, of course, if you read about diet, I can tell you overall, oh, eat fruit and vegetables, don't eat bread overall. But just about in general, Mediterranean food is what Mediterranean diet, the Mediterranean food, I love Mediterranean food, is what is recommended. You're welcome. Yes. Say that again. I'm sorry. Uh, yes. Yes. Yes, there is the two most common symptoms of perimenopause. We are talking about perimenopausal symptoms. If I can identify any signs of symptoms that I could tell me that the menopause is around the corner. The two most common symptoms first is menstrual changes. So you may start skipping cycles. So you won't see your cycle for a month or two or three, and then your cycle come back again. When your cycle come back, it may be either heavier, it may be lighter. Some patients are less lucky and will have more frequent menstrual cycles. As I said before, it's shorter cycle right now. So if before you were seeing your cycles every 28 days, now you're seeing your cycles every 24 days and every 21 days. So it can be any spectrum in between having less cycle and seeing your cycle less frequent, or seeing your cycle more often, lighter or heavier. So why is that? Because in the 4 years before your menopause, then your body is trying to compensate, and there is a lot of hormone fluctuation. The body is very intelligent. So when you lack something, so the FSH, one of the hormones, will start increasing to produce more estrogen. It's gonna work at the beginning, and then it gets tired and go down. So you're gonna have that fluctuation up and down of your hormones, and that what causes also the mood changes, the fluctuations in the hormones. So that happens at the beginning. So irregular cycles, abnormal cycles is gonna happen, and occasional hot flashes are the two most common symptoms of perimenopause. How do you know this is perimenopause? You're still seeing your cycles every so often. If you didn't see your cycle for 6 months and then it came back, you're not postmenopausal yet. Remember that by definition is 12 months completed, not cycle. So those are the two most common. Yes, ma'am. Yes. Ah, so I gotta give you two answers. So I have a story here is you didn't see your cycle for a complete year, and the next month, so 13 months after you got your cycle, a week after a year. But after 12 months of amenorrhea, then the cycle return. Is this normal? No. So as a provider, and I can tell you my other side, so either provider, woman, what's going on. As a provider, any postmenopausal bleeding deserves an endometrial biopsy and is endometrial cancer until proven otherwise. Okay, good. So you have a good provider. So yes, this is what happened. Endometrial cancer is not the most common cause of postmenopausal bleeding. It's one of the less common causes of postmenopausal bleeding, but it's the most dangerous one. So this is the first thing that I want to rule out. Okay, you don't have postmenopausal cancer. Okay, let's talk about bleeding now. What's going on? Don't worry about it. You don't have anything. Come back, if it comes with returns. But we need to rule it out. So endometrial biopsy or any intrauterine assessment, ultrasound is the next way to go. You are this week the second person that tells me exactly the same thing. I didn't see my cycle, but now my daughter is 12 years old and she got the cycle. We got it together. Yeah, I'm one of three girls. I'm one of three girls. We all had our cycle together. I cannot prove that by any. So for now, until there is some literature agreeing with that, I have to say it's abnormal after 12 months, and you need assessment of the endometrial cavity. Yes. No, no, you postmenopausal. So your ovaries, when your ovaries stop working and now you are postmenopausal, this is non-reversible. It's non-reversible. So you are postmenopausal, your eggs are done. Remember the eggs, you're born with your eggs. So when they're done, they're gone. You don't have any more eggs, you don't have them. So that's why we know that this bleeding is not related with any hormonal, it could be related with hormonal, but it's not related with your cycles because now your ovaries are not producing that estrogen. There are multiple causes of postmenopausal bleeding though. If you're taking hormones and you had a patch and then you remove it, it is normal that you may have some withdrawal bleeding, call it withdrawal bleeding. Well, I was having hormone replacement therapy, but I forgot today, or I ran out and never put it back. It is expected. So I know this is, so, the different causes, but not related with your menses. This is not your menses, even if you have it every month. It needs to be addressed. Mhm. Yes. Yeah. Yeah. It's more healthy. Yes. Yes. Exactly. Mhm. Yes. Definitely. Mhm. That will help. Yes. So we're talking here about how to spread the calories. We are concerned that now if we eat 5 or 6 times a day, you're eating more calories and want to stay in the amount of calories that we spoke in the past. So there, I said five to 6 times a day, small, healthy. So those two words is very important. So if you're eating fries 3 or 4 times a day, of course, not gonna work. So that's very important. Exactly how you set it, you're gonna spread it through the day. Small, healthy snack. And when I say small, healthy snack, it could be like a tablespoon of peanut butter. You know, it could be, yes, it could be a boiled egg. It could be an apple, half an apple. It could be a portion of yogurt, like 3 tablespoons of yogurt, like a Greek yogurt. So it doesn't have to be like a whole meal. It's just to keep that metabolism working. Okay. Yeah, go ahead. Yes. Yeah. Okay. Very important question. The question here that I have is there a certain point that we have a cutoff of age in terms of using hormone replacement therapy? The answer is no. There is no specific cutoff. We try as a provider to slow down or try to decrease the dose of the hormones after 65 years old. There has not been a clear literature giving a specific cutoff that is patient related and that is a shared decision making. When I have a patient using hormones for a long time, we can try to stop it because maybe you won't need it anymore, but I won't know until I stop it. Most of the patient will have postmenopausal symptoms for around 10 years or so. So if you did had your last menstruation at 51, maybe at 61, you may be good. So we can try to slow down, maybe decrease the dose of the medication that you're taking. If you have your symptoms, again, I'll give it back to you. I don't have any card of where I said, no, you are too old, you don't deserve it anymore. That's not a thing. You have the symptoms, we need to treat it. Okay. Yeah, sure. So you need to go back there.
We
Some more
have
questions.
one more question over here. Can you speak about natural supplements that can help with symptoms if someone doesn't want hormone replacement?
Um, yes, there in terms of hormone replacement and natural, there is a lot of literature out there that is what is called also bio identical hormones. The literature not necessarily go in there too much. It may be some placebo component to it, which works. Like if you take a tea every day and that works for you, you don't have any hot flashes. Don't get me wrong. If that works for you, that does work, and that's very good. There are some teas like ginkgo biloba, quajon, that are different teas, but they have not been proven that they are very effective in terms of controlling the symptoms. But there is a lot of options out there. We followed ACOG, which is the American College of Obstetrics and Gynecology. They haven't recommend to use it as a first line treatment.
Great. Thank you so much. And with